Hey everyone, and welcome to This Explainer. Today, we're tackling some of the absolute most complex, high-stakes cardiovascular and pulmonary board scenarios you're going to face on the USMLE Step 3. If you really want to master the wards and totally crush this exam, you need to understand not just what to do in a medical emergency, but the exact diagnostic reasoning behind it.
Here's our roadmap for today. We'll kick things off with the next best step framework, move into acute heart failure, cover HFEF and cardiotoxicity, navigate the complexities of HFpEF, and finally wrap up with massive PE emergencies. Let's get right to it.
All right, Section 1, Mastering the Next Best Step. This is the primary framework we'll be using to conquer Step 3 today.
Listen, this exam isn't just about spitting out memorized facts, especially when it comes to the CCS cases. It is all about real-time diagnostic reasoning. You have to quickly formulate a differential from the clinical vignette and instantly identify the most urgent clinical priority. But here's the crucial part. You must actively deconstruct why the distractors are wrong. Mastering this test requires understanding exactly why those wrong answers are incorrect, not just hunting for the right one.
Moving right along to Section 2, Acute Decompensated Heart Failure. Let's dive right into our first clinical case.
Okay, picture this scenario. A patient presents with progressive dyspnea, orthopnea, a left bundle branch block on their ECG, and bilateral effusions with a pleural to serum protein ratio of less than 0.5. So, what's the next best step? Pay really close attention to those clinical clues. That left bundle branch block, it's a classic surrogate for left ventricular hypertrophy pointing to chronic pressure overload. And that ratio of less than 0.5, that is a textbook Lights criteria finding.
And the correct answer here is intravenous loop diuretics like furosemide. The absolutely vital point is that diuresis immediately reduces intravascular volume and pulmonary capillary pressure. It alleviates the congestion that's actually causing the effusions. Plus, it serves as a diagnostic maneuver, a dual-function therapy that the Step 3 examiners absolutely love. If the patient's symptoms improve with diuresis, it heavily reinforces your initial diagnosis of volume overload from heart failure.
As you can see by looking at Lights criteria, our patient's fluid is transudative. It's driven by increased hydrostatic pressure. Literally, the fluid is just getting pushed out of the vessels without any inflammation. An exudative effusion, on the other hand, involves active inflammation or a vascular leak. Because that pleural to serum protein ratio is less than 0.5 and the LDH would be less than 0.6, we know definitively this is a transudate. Therefore, our treatment approach has to focus entirely on volume management via diuresis, not going down a rabbit hole hunting for an infection.
Now, let's actively take down a really common, dangerous exam trap. Why not empiric IV antibiotics? Well, as we just established, this isn't an exudative effusion. Our patient has no fever, no pleuritic chest pain, and zero systemic signs of infection. Administering empiric antibiotics here isn't just slightly wrong. It actively exposes the patient to unnecessary and potentially dangerous risks like nephrotoxicity, antibiotic-associated diarrhea, and antibiotic resistance.
Here's another incredibly tempting distractor you'll see: chest tube insertion. Do not fall for this. It's massive overtreatment for a transudative fluid. Tube thoracostomy is typically reserved for complicated parapneumonic effusions, MPMOs with frank pus, or large malignant effusions that are causing severe, life-threatening respiratory compromise. Shoving a chest tube into our patient unnecessarily exposes them to bleeding, infection, or a pneumothorax. Picking an invasive, unnecessary procedure like this will literally tank your score on the CCS cases. Safely reducing hydrostatic pressure with IV furosemide is the only right move.
Section 3. Managing HFrEF and cardiotoxicity. Let's see how our management strategy shifts as we move from the acute inpatient setting over to the chronic, nuanced outpatient management of heart failure.
Here's your next vignette. A stable outpatient presents with new-onset heart failure, meaning a reduced ejection fraction of less than 40% following recent anthracycline chemotherapy. What's the most appropriate first intervention? Take note of the specific trigger here. We have a toxic exposure from chemotherapy in an otherwise hemodynamically stable patient with totally normal vitals and zero signs of acute decompensation.
The correct answer here is to initiate guideline-directed medical therapy with an ACE inhibitor, like lisinopril. Regardless of the trigger, even if it's chemo-induced, early initiation of an ACE inhibitor is foundational. The whole goal here is shielding the heart. It immediately blocks maladaptive neurohormonal signaling, specifically the renin-angiotensin-aldosterone system, reduces afterload, and promotes beneficial cardiac remodeling to actually improve symptoms and reduce mortality over time.
Before we look at the broader treatment steps, let's unpack the pharmacology real quick, because in thoracic line cardiotoxicity is a hugely testable board concept. Doxorubicin is notorious for causing dose-dependent dilated cardiomyopathy. It works by generating free radicals that lead to myocardial cell apoptosis and progressive thinning of that ventricular wall. So how do we prevent this? We use dexrazoxime. It's a cardioprotective agent that chelates iron, significantly limiting that oxidative damage when you give it prior to the infusion.
So stepping back to our patient's management, here is the heavily tested, step-by-step timeline of guideline-directed medical therapy. Step 1. Start the ACE inhibitor, like lisinopril, to reduce afterload. Step 2. Achieve clinical stability, and you've got to monitor closely for hypotension or renal dysfunction. Step 3. Once they're stable, you add a beta blocker, like carvedilol, to mitigate chronic sympathetic stimulation. You must wait for established afterload reduction before adding the beta blocker to avoid worsening cardiac output or dropping their heart rate too much. Finally, Step 4. Reassess at 3 months. You only consider an implantable cardioverter defibrillator, or ICD, if the EF remains at or below 35% despite optimal medical therapy.
This brings us to a really vital comparison, an ACE inhibitor versus loop diuretics alone. Why are diuretics alone the wrong answer for chronic management? Because while loop diuretics definitely relieve congestion and make the patient feel much better today, they do absolutely nothing to buy them more time or improve long-term survival. ACE inhibitors and beta blockers actually save their life by targeting those maladaptive neurohormonal mechanisms.
All right, Section 4, Navigating HFpEF Complexities. Let's move to a whole different beast, heart failure with preserved ejection fraction, or diastolic dysfunction.
Consider this complex, multi-layered vignette. An elderly patient presents with JVD, bibasilar crackles, an S4 heart sound, and concentric LV thickening on her echo. This is a super classic presentation for HFpEF, a stiff, hypertrophied left ventricle. But suddenly, she develops new-onset atrial fibrillation with rapid ventricular response. What's the next best step? In this scenario, the patient's non-compliant ventricle relies heavily on adequate diastolic filling time, which is suddenly being totally compromised by this tachyarrhythmia.
So the absolutely crucial point here is the delicate balancing act you have to perform. First, address the acute volume overload with cautious loop diuresis like furosemide to lower those left-sided filling pressures. But be incredibly careful, do not over-diurese. These stiff ventricles actually require higher diastolic filling pressures just to fill properly and maintain cardiac output. Once initial diuresis is achieved, we have to slow the heart rate down to increase diastolic filling time, usually with a beta blocker like metoprolol, and avoid pure vasodilators like hydralazine. They do absolutely nothing to address the underlying diastolic stiffness and might even trigger a reflex tachycardia.
When you're choosing how to control that rapid heart rate, beta blockers are your right answer. Metoprolol slows AV nodal conduction and buys the heart more filling time, while beautifully avoiding negative inotropic effects in a ventricle that is already stiff. Let's quickly deconstruct the digoxin distractor here. Digoxin is strictly a second-line agent. It lacks any proven mortality benefit in AFib, it's way less effective in high sympathetic states, and it carries major toxicity risks with a very narrow therapeutic window, especially in older patients. It is a classic exam trap. Don't fall for it.
This summary perfectly illustrates the overall strategy across the 3 main clinical stages of HFpEF. If they come in with acute volume overload, your primary goal is to relieve that congestion with loop diuretics. If there's concurrent AFib with rapid ventricular response, your goal is to increase diastolic filling time using beta blockers. And for a stable outpatient with HFpEF, your primary goal is strictly controlling blood pressure and reducing adverse remodeling. In that case, angiotensin receptor blockers, or ARBs, like losartan, become your first-line therapy to improve compliance and prevent future decompensations.
Section 5. Massive pulmonary embolism emergencies. For our final case, we're shifting gears completely to a terrifying, high-stakes pulmonary emergency.
Okay, listen closely to this presentation. A patient suddenly develops obstructive shock and sustained hypotension. A point-of-care ultrasound shows right ventricular dilation with septal flattening. What is the next best step? The clinical urgency here is massive. Obstructive shock combined with acute right heart strain means this patient is hemodynamically unstable and rapidly deteriorating due to a massive pulmonary embolism.
The right answer is immediate systemic thrombolysis using alteplase. You absolutely must urgently dissolve the clot to restore perfusion and right ventricular function in an unstable patient like this. But let's look at a deadly exam trap, CT pulmonary angiography. Do not fall for this on step 3.
Sending an unstable, hypotensive patient down the hall to the CT scanner is a deadly delay. Diagnostic imaging should never, ever postpone life-saving reperfusion therapy when a massive PE is clinically obvious and the patient is crashing in front of you.
Which brings us to a final critical question for your practice and your board exams. In the chaos of a true emergency, will you rely on your clinical diagnostic reasoning to administer a life-saving drug, or will you let the perfect scan become the enemy of survival? Trust your clinical judgment. Rely on these foundational pathophysiologic principles, and you'll not only master the USMLE Step 3, but you'll save lives on the wards. Thanks for joining me on this explainer, and keep learning.